everybody who are listening to this talk. So today we have Dr. Raj Ayyagari from Yale, who is the Associate Professor of Radiology and Biomedical Imaging. He's also an Adjunct Associate Professor of Urology. He's a Director for Male Interventional Health. So this is an interventional radiology. You actually usually do vascular and endovascular surgical procedures, urology and pediatric procedures. So welcome, Dr. Raj.
Okay, thanks. All right, well, thanks everyone for tuning in, and I hope to meet you guys someday soon. I've been wanting to come over and visit. My wife is an obstetrician, and so she also wants to come, and we just have two kids, little kids, and we have to figure out childcare. Otherwise, this year, travel restrictions permitting, we'll probably make it over there. And then maybe we can do one of these, or a couple of these cases. So I'm going to talk to you guys about prostatic arterial embolization as a minimally invasive treatment for BPH, which is benign prostatic hyperplasia. I have no disclosures. So BPH, benign prostatic hyperplasia, is a histopathological diagnosis. BPH causes bladder outlet obstruction, which we call BOO, and it was also known as benign prostatic obstruction. It's very low incidence in young men, but as men grow older and older, it gets very, very common, and up to 80% of men worldwide have BPH when they're in their 80s. No major mortality by itself. It doesn't kill you by itself, but it has major impacts on morbidity, quality of life, and healthcare costs for a big part of the population of the world. Specifically, it can lead to urinary tract infections, hydronephrosis, and even renal failure. Lots of times people can also get bladder stones. They can have severe hematuria, gross bleeding in the urine. And just so a quick diagram here, on the left of the screen is a normal sized prostate, and you can see the anatomy. The urine exits the bladder, the prostate sits around the bladder neck, and the urine passes through the urethra and out the penis. When the prostate becomes very enlarged, the central parts of the gland are typically the parts that grow the most, and they can really impinge on the outlet of the bladder and then cause urine to not really flow very well. So when we diagnose patients, everywhere in the world, this symptom score is used, the International Prostate Symptom Score. Pretty much everywhere in the world you go, you'll see this. It's basically 7 questions that a patient is asked. And they rank each symptom, so 7 symptoms, 0 to 5. 0 is basically nothing, there's no problem at all, and 5 is terrible. You ask a patient about incomplete emptying, how often do they urinate, their intermittency with the stream stops and starts, urgency when they have to run to the bathroom, weak stream, straining, having to push the urine out, and how many times they get up at night. And then we also ask this bottom quality of life question overall, like how happy are they with the situation? 0 is good and 6 is terrible. And then once we add these scores up, we get a total score, and we kind of rate the severity. We also ask people, the SHIM is a sexual health inventory for men. It gives a number about how good their their erectile function is. We also measure urine flow rates, and we can use this kind of device to have the patient urinate in. We can also measure the post-void residual with an ultrasound, where we see how much urine they have left. We like to measure gland size as well. And then when we're not really sure what's going on with the patient, sometimes they can have lots of other problems that have the same overlapping symptoms, like overactive bladder or bladder stones or some other problem. We'll get a much more invasive, complicated urodynamic study, but this is really complicated, and we seldom actually get it. And actually, this happens to be a female diagram here, but this is basically just, you put a catheter into the bladder, another catheter either into the rectum or the cervix, and then you measure all sorts of kind of urinary parameters. Now, medical therapy, when symptoms aren't so bad, you start off with medical therapy. We can give first alpha adrenergic antagonists. Very common one, at least in the Western Hemisphere, is tamsulosin, probably worldwide. We also use taurizocin, alfuzosin, and doxazocin. And they basically relax the muscle, the smooth muscle around the bladder neck and the prostatic capsule to help urine flow better. We also use 5-alpha reductase inhibitors, which inhibit the action of the action of testosterone. And because the testosterone is the hormonal influence that makes the gland tissue grow to begin with. While these do improve the symptom scores, modestly, they have a lot of side effects, decreased sexual function typically. They can also make you hypotensive or dizzy. And so lots of patients end up not taking the medications. Some people also take Cialis, which is actually a phosphodiesterase inhibitor, which has been used to treat erectile dysfunction because it also helps with urinary flow. But when medications aren't enough, or when patients can't tolerate the medications, then it's time to talk about some kind of surgery. Probably worldwide, the TURP, the transurethral resection of prostate, is the gold standard and probably the most common thing worldwide for a surgical therapy. It's effective for more severe disease, generally for glands that measure up to 80 to 100 milliliters in size, but maybe up to 120 depending on the urologist's experience. It will reduce that symptom score, that score. It'll reduce it by about 70%, which is the gold standard. It's the best of everything out there. And it has excellent, improvements in urine flow as well. But it's invasive. It can be bloody or painful. It requires general or at least spinal anesthesia. Usually patients need to be admitted. They have to have a catheter in. It's not good for large glands, bigger than 120 milliliters. There's a reoperation rate of 15%. Also, about 10% of patients get erectile nerve damage, and about 2/3 have retrograde ejaculation. There are also more complications with it, as you can see there, and even small risks of even more severe things like urinary incontinence that's long-term, or bladder neck contractures that cause scarring. And so there are lots of downsides to the TURP. And that's why over the years, many throughout the world, different companies have tried to come up with different devices that can treat the problem in a less invasive way. There's something called green light laser. I'm not sure if it's available in your region. And a lot of people don't use it in the US these days either, at least in our area here. It's a little less invasive, but it's also a little less effective. It can reduce the symptom score by 60%, but also you can't put it on very big glands. There's something called a holmium laser nucleation of prostate, HOLUP, which is really good for big prostates, but it's a very technically challenging procedure, and it's only done by a select few surgeons. And also, apparently, it doesn't pay very well. So a lot of surgeons, lots of hospitals are not really motivated to do it because it's a lot of hard work for not much reimbursement. So then there's something, and again, this is rather new, so I'm not sure how prevalent you guys have seen it at all in your region, but a procedure called Eurolift. It's for small glands. They basically go up the urethra, and put these little tacks in to open the gland up. It is good for small glands. It doesn't do a whole lot in terms of symptom score reduction compared to the TURP. And it's, like I said, it's pretty new, but it's very, very low risk, very minimally invasive. So it's very popular. The problem is none of these really halt or reverse the underlying hyperplastic process. The HOLUP, they actually scoop out the whole prostate. And so sometimes, very, very rarely, and maybe this is more common in your region, people actually have prostatectomies not for cancer, but just for BPH, where they actually cut the patient open, cut the bladder open, and then go in and literally scoop out the whole gland, literally with their fingers. And it can be very invasive, very bloody. And this is a surgery that is incredibly difficult to tolerate, especially for older, sicker people. So as you guys know, interventional radiology really provides a lot of much less invasive, very effective ways for patients to get treatment for all sorts of problems. And BPH is no different. There are lots of people who are not candidates for the standard surgeries because they have very large glands, or because they have lots of other medical conditions. And also lots of people these days just want something less invasive. Maybe they have very good sexual function still, and they don't want to suffer the erectile function or the ejaculatory problems. So prostate artery embolization, or PAE, is a treatment for BPH that was discovered really in 2000, actually by an interventional radiologist named John Demerit, who trained at Yale. He published the first case report in the year 2000. and then it's just gone from there. So just a brief review of the anatomy. So it's really important to know the internal iliac artery, internal iliac artery anatomy. Obviously for prostate embolizations, but also for fibroid embolizations, if you're going to do pelvic trauma embolizations, postpartum hemorrhages, both of those situations, you have to work very quickly. And so it's very important to know the pelvic arterial anatomy. For the prostate, and most visceral organs in the pelvis, we're looking at the anterior division. So this is external iliac artery, internal iliac artery, common iliac artery, and then this is the anterior division. And the anterior division is what supplies blood to the bladder, the prostate, the rectum, and women, the uterus. And so the dominant supply from the prostate is typically from the inferior vesical artery, which branches into prostatic and urethral branches. And so we basically call the inferior vesical artery, the continuation of it that supplies the prostate, we call it the prostatic artery. There are lots of variations in the branching patterns of the internal iliac artery anatomy. Lots of also anastomoses between different arteries. So usually if you push the beads in hard enough, if you're embolizing something, you can get beads to almost, even if you're just in one vessel, you can get beads to almost every organ in the pelvis. So you have to be very, very careful and understand the anatomy well. These arteries, the prostatic arteries, even when they're big, they're small. Usually they're under 2 millimeters in diameter. So how is PAE currently done? Obviously, this is an interventional radiology suite. We have all sorts of different kinds of catheters that we use. There's this very fancy, it's a steerable microcatheter called a Swift Ninja. You really need to have a good microcatheters for this procedure because the vessels are so small. We typically use beads like Embospheres is the brand that most people in the world use for prostate artery embolization, although people have used PVA as well, and other brands. We have this fancy microcatheter with a balloon on the tip, which is also helpful to minimize the reflux of beads and complications. Sometimes we'll also put in coils for various different reasons, not to kill the prostate tissue itself, but to help make the procedure more safe by blocking those connections between the prostatic arteries and other organs. So when we are evaluating a patient, obviously do a full history and physical. Like I said, we get the symptom score, the quality of life score, this sexual function score. We look at post-void residuals and flow rates, basically a full urological workup. Oftentimes, at least in my area here, the urologists refer these patients, and so they've already been worked up all, for the most part. But then we also get lots of patients referring themselves, and so then we'll do the workup more completely as well. Like I said, sometimes we very rarely will get a urodynamic study if we're not sure what's going on with the patient, to make sure that we're treating the correct problem. I don't really ever bother myself to get pre-procedure CT or MRI imaging. I just found that it didn't really help my planning or change what I did. I do get ultrasounds, again, just mostly to measure just the gland size and the post-void residuals, so I know how bad a patient's problem is. So we basically, there are very, very, very few patients that are not good candidates for prostate artery embolization, as long as we know they are, they have BPH and we're treating the correct problem. We don't want to treat someone who has an active urinary infection. Even the large bladder diverticular stones, I don't think is a big problem. We just have to make sure they're not going to bleed from, if they're on a blood thinner. And also we're going to give them contrast, of course, in their vascular system, so we can't have anyone with kidney function problems. And again, we're just not going to treat people with this if we don't think BPH is the real problem. So the way it works, it's typically an outpatient procedure, lasts a little bit over 2 hours. The pain for the procedure is very minimal, so we sometimes don't even give any sedation at all. We give ketorolac or Toradol. It's a powerful IV anti-inflammatory to help with the pain during the that comes after the procedure. We can get femoral arterial access or radial arterial access. We get into the pelvic artery, pelvic aorta, and then we'll do bilateral internal iliac artery, anterior division angiography. Sometimes I do what's called a cone beam CTA, where we inject contrast, and if you have a fancy IR room, the imaging apparatus can spin around and do kind of a rough CT scan right there on the table. But I use that only maybe a quarter of the time to help help me figure out what's going on, do some problem solving, but I don't use it very often. So then each prostatic artery is selected with a microcatheter. Usually we use like a 2.2 or 2.4 French catheter. And then we embolize the prostate with, I use typically 1 to 300 micron embosphere beads. Lots of other people use larger beads, or they'll use PVA elsewhere in the world. Like I said, sometimes we have collaterals to other vessels that we coil them so that the particles don't go to other organs like the rectum or the bladder or the penis. And typically after the 2.5 hour procedure, we will observe them for 2 hours, and then we discharge them home the same day. So here is just an example of what the anatomy looks like. On the left of the screen, we have our 5 French catheter in the internal iliac artery. This is the posterior division. We have superior gluteal, lateral sacral, and iliolumbar arteries. This is the anterior division, and this black arrow is pointing at the prostate. Well, so this is superior vesical artery. This is feeding the bladder. And so you can see this is the patient's pubic symphysis here. The bladder will be here. This vessel comes down. This is the inferior vesical artery, which becomes prostatic artery and feeds the prostate. This is the blood flow of the prostate. This is the inferior gluteal artery, the pudendal artery, and this is the obturator artery. And again, this is the bladder full already of contrast that's been excreted in the urine. So this is just a frontal image where we've injected the prostatic artery. You can see this is the pubic symphysis. This is the obturator foramen. The bladder is going to be here, and then this is the right half of the prostate. And you can see the angiographic picture of the images there. And this is a cone beam CT. So this is something we've done on the table and acquired images, and you can see again the prostate here, the bladder, and then we're injecting the right prostatic artery. This staining here, the little white arrowheads, we've already embolized the left side in this case, so you can see some of the beads left there, or the beads sitting there as we then after went on to the right side. Okay, so I'll show you a case. So 70-year-old male with severe BPH, he'd failed medications. He was so bad that he had retention, had a catheter in for 16 months. He had multiple infections and lots of blood in his urine from his prostate. So when they have urinary retention, a catheter, and that symptom score is actually not applicable. He had a very large gland, 245. So this is the first set of images. He's facing forward here. This is subtracted digital subtraction angiogram. This is the balloon for his Foley. His pubic symphysis is here. His hip joints are here and here. We got right femoral access, put a catheter up into his pelvic aorta, and inject a contrast and do this run. You can see. So usually, if a prostate's normal size, the Foley balloon will be around here. So you can see how much bigger his prostate is than normal. So we got into his left internal iliac artery, and now this is an oblique position, and there's a lot of vessels here. So that's the Foley. So this is his superior vesical artery feeding his bladder. This is his internal pudendal artery, which will feed the penis, the scrotum, the anus, the perineum. That's his inferior gluteal. This is his middle rectal artery. This is his inferior vesical artery. What's missing? His obturator artery, which he had an external obturator artery. So some people will have, it's called the corona mortis, where the obturator will come off the external iliac artery. Anyway, so we get selective, and now we're in a superior vesical artery there. That's the green. And you can see the branches to his prostate. That's the left half of his prostate. And this is the corresponding axial image of cone beam CT. You can see the opacification with contrast of the blood vessel of his left prostate. So we embolized from there with beads. Then we went to his right side, got into the internal iliac artery. There's the Foley balloon. That's his superior vesical artery. That's his pudendal artery. That's his inferior gluteal artery. That's his obturator artery. There's his inferior vesical artery. And you'll see this little branch there, which we didn't know what that was, but we will come back to that. So we did a frontal angiogram, Foley balloon. Now we're in the vessel, and we do a cone beam CT, and it looks like we're good. You can see all this blood flow to his right prostate. Again, there's the staining from the embolization of the left prostate. But then this is his rectum, and we see this little blood flow back there. So we stop, and we do an oblique view here. And as we inject, you can see this is our angiographic catheter. This is the intravesical artery. But then there's that little connector that we saw before. And what is that? It's going to his middle rectal artery. So this is a branch going to his rectum. This is a good illustration of all the anastomoses that we've seen. These are all normal and very common. So that's coming off his inferior mesenteric artery. So we put a coil in right here. And with the coil, it plugs up the flow. And then now when we do the run, you can just see contrast just goes just where we want to go, just the process. So we put the beads in, and the case went well. At 12 months, he got his catheter out, and his symptom score is down to 3. Remember, 1 to 7 is mild, so he was very happy. His quality of life was 0, which is the best. His post-void residual was very low compared to having complete retention before, and his gland volume decreased by 25%. And you can see how his gland shrunk, and you can see even the shrinkage around the prostatic urethra. And he also had improvement in his erectile function, which happens in about maybe 10 to 15% of patients, and we don't exactly know why. But so this is our data from Yale, just in terms of success. Patients who we've done embolization for urinary retention. So we studied this a few years ago, published this about, first we had 43 patients in retention. At 3 months, 34 of those 43, we got their catheters out and they were voiding well. At least 4 of them we'd gotten, rather than having indwelling Foley, to just self-catheterization, which was less than having an indwelling Foley, and 3 still had their Foley. So you can see as we march out our data all the way out to 3 years, we have at least about a 75% success rate in getting patients out off catheters and having kind of a normal urination pattern. So that's a great success rate, actually. And these are patients who are usually not surgical candidates. So these are patients who would otherwise be stuck with a catheter for the rest of their lives. So, and then their symptom scores went down from, infinite, basically, with having a catheter in, just nice and low, kind of within the mild range over time. So first they're 9, but then as we marched out to 3 years, they're really under 7. So they are in the mild range. So they did really well. Another case, now this is so for LUTS, abbreviation for lower urinary tract symptoms. This guy had bad symptoms. He failed his medications. He had a pretty high symptom score, high post-void residual, big gland. And his flow rate was low, and he could not have surgery because his gland was too big. So again, the usual anatomy, we get into internal iliac artery anatomy there. This is posterior division, anterior division. The green is the inferior vesical artery. You can see the vessels feeding his big prostate. Again, just a selected unsubtracted view. You can see the big gland there. So this is a nice cone beam CT image to really show you the same anatomy. Really nice opacification of his gland. We embolize that side. Then on the right side, very similar story. Got into his inferior vesical artery. See the vessel, and you can see now his bladder filled with contrast as the urine, opacifies. And just a closer look, you could see some of these glands are very big, very vascular. So we, again, a corresponding cone beam CT. You can see now we're injecting the vessels on the right side. This is staining from the left side. This is his bladder full of contrast, opacified urine. So he did great. At 3 months, his symptom score went from 23 down to 6. Quality of life was down to 0. His post-void residual basically went back to normal. His gland size shrunk to about half, which is more than average. Usually we get about 30–35% shrinkage of the gland. And you can see just on CT images how much his gland shrank. So it shrank to the point where you can actually see now that, like, parts of the penis in the same axial slice there. So then we published our data on just patients with lower urinary tract symptoms, and we had an average of about 22.5 when they came in, which is severe range. And then again, tracking out over 2 years, they respond very nicely with about almost a 70% reduction in their symptom score rate, which is equivalent to the gold standard. If you remember, I said TERP has about a 70% score reduction. So those are excellent data as well. And then we looked at, again, the gland size and how much their post-mortem residuals shrank after embolization. Again, those were all really good numbers. And that's just a lot of data we're not going to talk about. And finally, a third case, this patient had severe gross hematuria. It's in the hospital with the catheter pumping irrigation in. And in fact, I have a patient, we got consulted today, and we're going to do his embolization tomorrow. We do a few of these a week typically, so we do a lot of these here. But this guy came in, and so you can see we've selected his right, so he's facing us. This is his right prostatic artery. This is his prostate here, and this is his bladder, full of contrast. And you can see when we first, even though we're on the right side, the vessel's feeding his left prostate gland, and we see that every once in a while. So we treated his left side first, and then as we filled up the left side of his gland, then the beads went more preferentially in his right side of his gland. And then we embolized his right gland, and we did it all from one arterial axis. It's very nice, very convenient when this happens, but it's very rare, of course. And so these are our data. So he cleared up afterwards, he did great. These are our data in terms of gross hematuria treatment after prostate embolization. So the orange patients are patients with gross hematuria where it's not, they just have blood in the urine that you can see. It's not severe, like they're not in the hospital getting transfusions and irrigation. But the red ones are the severe patients who are in the hospital getting transfusions and irrigations. And so at 1 month, you can see, so the yellow are, just clear urine with no blood. Now this is gross. They may have microscopic blood if you do a urinalysis, but you can see the severe, we got complete resolution, and almost all of the gross hematuria patients got much better. And over time, we have really great success rate with this. The blacker patients would just die over time, so we have to exclude those, of course. And of these patients who had persistent hematuria afterwards, most of them were usually on blood thinners as well. They were like stroke patients, so the fact that but they were a lot better than they were anyway. So great success rates there. So these are the complication rates. Urinary tract infections are the most common thing, but they're still pretty rare and usually mild, and we just treat them with antibiotics. A few patients have had issues where we give them contrast. These are older male patients who have borderline renal function typically. Then there've just been mild scattered other little complications that generally are pretty minor. Some patients will go into urinary retention afterwards from the inflammation and the swelling in the gland, and we have to put a catheter in. We had one patient have a pretty significant ischemic problem with tissue damage to the tip of his penis, but he did fine and got his catheter out, so he was very happy. And we've had 2 patients who died shortly after the procedure, but for unrelated causes. So take-home points here. If you want to know what patients will be a good candidate, basically anyone who's failed medication therapy and someone who is not a good surgical candidate because of their health conditions or their large gland size. Patients who are already walking around with Foley catheters are the obvious patients. Any patient who's on a blood thinner would otherwise not tolerate surgery because of bleeding risk. Patients who are, like I said, on blood thinners who have lots of blood in their urine. Or some places, especially in the United States, there are long wait lists for surgery. And so sometimes embolization we can get to them quicker and more easily. And the nice thing about it is if it doesn't work, you don't burn any bridges. Patients can still take medications. Patients can still undergo other surgeries. And in fact, by shrinking the gland and cutting off much of its blood flow, if nothing else, we make those surgeries safer and easier. And then, like I said, lots of, these days, more and more patients just find out about newer and better, less invasive options, and they want to, not to suffer. So that's it. So this is my email and my cell phone if you ever want to send me a text. And that's it. Are there any questions?
So thank you, Dr. Raj. Anybody who have a question or comments right now, they can ask or make those comments. Please welcome.
Yeah,
anyone.
I have a question. Can you talk a little bit, because you have as we could see over a lot of follow-up data. It looks like at least during the first year you usually have pretty much complete follow-up, and now that the senior fellows in Tanzania have worked on their first major research projects, we've really realized that we have a ton of issues with follow-up. Can you talk a little bit about like how you achieve such good follow-up and sort of what infrastructure you need for that?
Well, for better, for worse, there's no infrastructure. I just call them. I take lots of time, and I keep all my lists of all my patients, and I just call them. Like a lot of the follow-up can be done over the phone or with like video chatting, because you can just send them that symptom score sheet, or they can, if they have online access, they can look it up, and they can just give you the numbers. They can tell you how they're doing. They can tell you if they've had any urine infections. They can tell you if they've had to go back on a catheter, or if they've been able to stay free of catheters. They can tell you if they've seen any blood in the urine. They can, hopefully tell you what medications they're on. So a lot of that information you can just get by calling them. And so that's what I do for, even before, the COVID pandemic, I did a lot of just phone follow-ups. And now with COVID, and at least in the United States, we do a lot of telemedicine now anyway. So, and so I just keep a very active list that I keep checking over and over and over again. And in fact, I made this big database on Excel, which is very expansive and mature. And I put a lot of code in there to kind of like, every time I open it, it constantly updates me as to which patients are due for, which follow-up point. Is like, just a simple, if how to write a little bit of program. Actually, Doug Sillen helped me write that little code, but it's easy to do. And then I have them get ultrasounds, and I measure and it's a simple ultrasound that measures their gland volume and their post-void residual. And so, and I have patients come from, all over different parts of the country. And so the ultrasound is something that, it's very, relatively speaking, very cheap and easy to get. And most patients can get that just, somewhere locally. And so I imagine, in Tanzania as well, among all the different imaging studies that you might, try to get, ultrasound, I'm sure, would be the easiest and cheapest and most accessible to patients. So, yeah, so just spending the time to call them. And then again, a lot of this follow-up is very easy to get over the phone.
And you do 1 month, 3 months, 6 months, and then 1 year, and then every year, or?
Yeah.
Okay.
And the 1 month visit is usually kind of like a post-operative check to make sure they're doing okay, make sure there were no problems. And by 1 month, usually they have had most of the improvement they're going to get. 1 month for the catheter patients, and that's when we try it's called avoiding trial, to try and get the catheter out. And for the patients who've done really, really well, sometimes we'll stop we'll talk about stopping their BPH medications at that point. But then at the 3 month point, that's when most of the shrinkage has occurred by then. And so they should have reached their full symptom improvement by the end of 3 months. And at that point, that's when we talk more about, stopping their medications. We can usually stop their medications about 60% of the time, the BPH medications. And so we'll stop medications then. And at the 3 month point, we'll say, okay, this is the, you've reached the full effect. And then at 6 months, I just like to see that they're having sustained success. And then, just yearly, just for, because it is, somewhat new. We now have published 5-year data, but it'll be a little while before we have 10-year data. So it's really important just to, because we don't know the long-term data on this procedure yet, to follow these patients. But we'll know, we do embolization, obviously, in all other parts of the body. We've been doing it for decades. For women with uterine fibroids, it's very similar pathophysiology and very similar procedure. I don't know how many uterine fibroid embolizations you guys have seen, but so it's likely that these patients will have similar, long-term, high rates of success, especially since a lot of them are in their 60s, 70s, and 80s anyway. I'm not sure how much 20-year data we'll ever get, because a lot of these patients won't live 20 more years, but yeah.
And are these follow-up intervals sort of standardized in the literature, or is that something you just decided on, like the one?
I don't know, really. I guess I definitely decided on it. I don't know if it's standardized, but I think they're common, at least. I think I'm more I think I probably do more follow-up than most people. I like, more frequent follow-up than most people. And I would say, I try and do a lot of research and publish a lot of things, and I try to really collect a lot of data. And I'm not sure if it's really, you could, you have to do the 1 month follow-up, just because you did a procedure on a patient. And the 3 month point is pretty important because that's when you're modifying medications and things. And the annual follow-up, I mean, those, the 6 month follow-up you could probably skip, and the annual follow-up, again, it's more just like any patient's going to see the urologist annually. They're getting their PSA checked for prostate cancer screening and so on. So I think it's pretty standard, most of it.
And would you do similar for UFI, or for UFI you would see them less? You would just do like
UFI, yeah, no, UFI. So UFI, I see them the 1 month mark just for post-op check. Then we see them at 6 months because we're not really changing medications per se. We get a follow-up MRI to see how well their fibroids have shrunken. But they'll tell you, I mean, for them, it's mostly it's bleeding, right? And or bulk symptoms. And so those things just get better, and they can just, they'll tell you if they're not better. And they don't, well, because women go through menopause, right? And that's the big one. Once they go through menopause, the hormonal influence on the fibroid shrink, is much lower. And so they'll usually, if we've done a patient in their early 40s, by the time they hit 50 or so, they go into menopause. So then the fibroids never come back, really. They're not a problem anymore. Yeah, so it's not the same. You don't have to worry about this continual functional problem of urination. Is it going okay? It's not going okay. But also, unfortunately, for men, that hormonal influence doesn't go away. So it continues to be a problem until death.
So we have 2 questions from the audience. The first question is from Dr. Latifa from Tanzania. She's asking, do you sometimes have repeat procedures? And the second question is from Dr. Ofonime Ukwe, who is asking, is there a role for prostate artery embolization in patients with malignant prostatic enlargement?
Yeah, so repeat patients, so far they've been very rare, but it'll take 5-10 year follow-up to really see what the repeat treatment rate is. I've retreated, well, I'll say I've probably had maybe, I don't know, 5 to 10% of patients who they went in, no, let's say 5% of patients who had improvement they got their symptoms down to the mild range, and then they got worse again over time and went up to like kind of medium range. Some of them, they had more like bladder issues separate to BPH, where they had like overactive bladder or bladder stones, or even we found bladder cancer and things. Anyway, maybe about 5% or less of patients actually go back and have some other BPH treatment done. I've re-embolized maybe 2% of my patients. I've had another, I don't know, 3 or 4% go back and say, oh, embolization didn't work, I'm going to go have a TURP done, but it's low. And I don't know what the causes are. Usually it's, I don't know why. Some patients, I felt like I treated them very effectively, and I was very surprised to have them come back. Some patients, I see them, I know, like maybe I didn't get enough beads in or something. It doesn't surprise me, but it's so few patients. It's really hard to make any, like scientific statements about it. And re-embolization is totally possible if we didn't do a good job before and the vessels are still open, you can get back in. I've retreated other people's embolizations from other centers, about maybe half a dozen patients. In terms of, yeah, and so there's another question there. PVA is definitely an option. There are lots of people in the world that use PVA, but more previously, I think now most places that I know of that do a lot of it use beads, the Embosphere beads. So I don't know if there are the current state, if there are many centers still using PVA, but in terms of treating malignancy, no, it doesn't really so the infarction usually occurs in the central kind of periurethral areas of the gland. The outer shell, the peripheral zone, does not get infarcted, and that's where about 80% of prostate cancers show up. So I've actually had plenty of patients who develop prostate cancer. Maybe they had it before, or then they get it, it becomes evident afterwards, and they go and have something else. Actually, I'm treating a patient today. Now totally separate talk, but we're doing MRI guided prostate ablations for prostate cancer. So we're treating a patient today for that. But so that's it.
So there was another question, which was he was asking, Dr. Baloa from Muimbili, Tanzania, also was asking, what is the treatment success rate?
Oh yeah. So I'd say usually I tell people 7 out of 8 for the lower. So there's 3 different things, right? So for the lower urinary tract symptoms, I tell people about 7 out of 8 patients have a really good result, which means getting down into the mild range of symptoms. For the retention, I say about 3 out of 4 patients get their catheters out and stay out and back to like a normal, reasonable urination pattern again. For the gross hematuria problem, I say it's over 95, maybe 95% of patients have complete cessation of the bleeding. And those who don't have complete cessation, usually they're still a lot better. And they're usually, and like I said, those patients are usually ones who are on blood thinners. So.
One more question, Raj. Like, I mean, you almost always use the sniper, right? Like, do you think, does it make a big difference not to use it? Like, let's say if you did one in Tanzania and that's not available, is that a big issue?
No, I mean, the first probably third of the patients I didn't have the sniper. So, and in fact, I published a paper saying that the sniper really made almost no difference at all.
And what did you compare to there?
Just kind of more standard microcatheters. I think a Renegade STC or maybe a Maestro. Probably Renegade STC is what I use typically previously. And I think it's more just, I think it allows me, the balloon allows me to do certain more fancy technical tricks and things that maybe make the procedure easier or maybe a little safer. But I did. There are plenty of people. I polled all the big name PAE people in the world who do a lot of this maybe half a year ago. About 15 people. I was the only one that used the sniper as my primary catheter. There's one other person who uses it frequently, but not as their primary catheter, and everyone else doesn't really use it. So there are very few people who actually use the balloon occlusion.
Sorry, so I have another question. So you said, I've heard you saying that some of the patients you follow them even for 10 years. So I was asking, I know this is an individual thing, but what's an average time do you usually follow up your patient?
I didn't. What was the question again?
So I was saying, I've heard you saying that some of the patients you follow them up even for 10 years, right?
Oh, you're breaking up there.
So what is an average time of following up a patient who was undergoing this procedure?
Oh, I don't know this average. I mean, I think it's very, you just have to see them multiple times. So definitely 1 month and 3 months. But like I said, the 1 month I see them in person, 3 months, and thereafter it's phone calls.
I think he was asking what average length of follow-up, like how many years?
I don't. Well, I'm continuously doing them. So, I mean, I have patients now 7, 8 years out. I've been doing it for 8 years. So it's hard to say an average. It's a constantly moving target because I have continuously enrolling patients. So I'm just going to keep doing it till I die or they die. So.
Many years then.
Yeah. We have enough patients with 5-year data now. We're publishing 5-year data. Coming up in the summer, probably within a year.
And for your base catheter, you use the sauce, right?
Yeah.
Yeah, because I think that's something that some of the fellows in Tanzania have not seen yet, because they're used to I mean, they haven't done prostate, but they've done you know, a good amount of fibroids.
We could use you could use a Roberts. I don't use it because the sniper doesn't go through it very easily, that bend.
They've used Roberts, C2, Bernstein.
Yeah. The Roberts is good. It's just like, well, for a while, the Roberts was unavailable, so I stopped using it. And then that at the same time, the sniper became available. And then when the Roberts came back, the sniper wasn't, it won't pass through the Roberts bend very easily. So I just never went back to the Roberts. But that would be, especially if you're not using the sniper, the Roberts would be a good catheter. So anyway, I think, so I guess I have to go start working on my prostate ablation patients. So thanks very much for inviting me, and I hope to see you guys soon. And if you have any, tell me what I can do. I have a he'll be 3.5-year-old and an 8-year-old. I need someone to figure out, tell me how I can figure out childcare for, you know, whatever, 2 weeks while I'm there. And if we can figure that out, or if I can just bring my kids to the hospital, let me know. And then my wife and I will come.
That'd be great. All right.
Okay?
Thank you so much.
I'm trying to figure this out. So if anyone has any good ideas about how to manage that, please.
Yeah, we'll think about that. We'll find something.
Okay.
Thank you, Dr. Raj.
Thank you.
Thank you very much.
Take care.